I think let us start. So Charles, it is a pleasure to have you with us. I am
Thank
Vivek
you.
Bindal, and we represent here the Clinical Robotic Surgery Association Indian chapter. Charles, or Professor Zhang, is a very good friend. He has been interacting and we have been meeting across the world for last 7 to 8 years now. And it has been an honor to have him today because they have a huge experience about how COVID-19 has impacted the surgical practice in China and what are the ways forward for each one of us who are out of practice because of this pandemic. Uh, Professor Charles or Professor Peng Zhang is a professor of surgery and chief of metabolic and bariatric surgery at Capital Medical University, Beijing Friendship Hospital in Beijing. Uh, he is also the secretary and treasurer for Chinese College of Metabolic and Bariatric Surgeons and executive council member, Chinese Society of Metabolic and Bariatric Surgery. Charles is an enthusiastic bariatric surgeon. He does a lot of clinical research and we work together in some projects at Duke University in US also. He has been talking about COVID-19, its impact on bariatrics in particular and general surgery in general uh, at various international fora. So we would request Professor Zhang to shed light about how pandemic played out in China and now are they back to work? What kind of precautions are they taking for the patients and for healthcare workers? Professor Zhang, please.
All right.
Excuse me, just give me a minute. So for everyone who wants to put in a question, there's a question and answer session right there. So I think you can type your questions and we'll take them up. We have a lot of discussion time. We'll take them up after the presentation one by one. Apart from that, there are few polls that we have created. So I think I am launching the first poll. So if you can see the first poll there, uh, how many surgical procedures are you performing in your practice right now? So not at all, less than 10% of what you used to do, 10 to 30% of what you used to do, and greater than 30% of what you used to do. So kindly vote and we'll have the results at the end. So this is just to give an idea about what kind of impact COVID has had on practice, on surgical practice in India. So still responses, I would next 5 seconds and we'll switch to the next question. Please respond. Yeah. So here are the results. So 29% of people are not doing any kind of surgical procedures. So they are all totally at home. Less than 10% is the majority. 53% of people are doing less than 10% of their cases. 10 to 30% is 11%. Greater than 30% is 8%. So a lot of decrease in the numbers. So a second poll there. So please answer this poll. We have 3 questions and then we'll go to the presentation. So we'll have some idea about what is happening. So are you getting COVID-19 test done before surgical procedures? Some people, yes, for all cases. Second option, for all cases except emergencies. Third, only patients suspected to be having COVID. And fourth is not available or not doing. So this is again a very important poll here because a lot of different scenarios are there in India. There are places where COVID-19 testing is not available. A pre-operative COVID-19 testing is not a part of ICMR protocol till now, while some governments have put this thing in place. So it is a question which has different answers depending on which area you are practicing in. All right, so we have responses here. Okay, so 38% majority are doing it for, all the cases. Majority means the maximum percentage. Then 23% are doing only for suspects, 26% not available, not doing, and 17% for all except emergency. So I think 55% are doing it for cases except emergency. Okay, and the last question here. So what precautions do you take for any surgical procedure? Like today, if you are doing a surgical procedure, what kind of precautions are you taking? Number one option is using level 3 PPE with N95 masks. Oh, this is mixed. This is not mixed, it is masks. Second option is using N95 masks, face shields, and HIV kits. Third option is use whatever is available in PPE and masks. And fourth option is use regular surgical gowns and gloves and masks. So, again, depending on various scenarios, you would be using different things. And this is to get an idea about the availability of PPE and N95 and various different protective equipment out there. Okay, ending the poll. All right, so 41% are using level 3 PPE with N95 masks. So most of people are trying to use the best available with them. 39% are using N95, face shield, and HIV kits. So I think HIV kits and PPE kits are different. So a lot of us know it. Some of us may need to know it. HIV kit is not impermeable to this virus. Use of whatever available PPE is 10% and 17% is regular surgical gowns. So 27% are using whatever is available with them, which is, oh, sorry, I didn't share. So this is, I think now you can see the results in front of you. Okay, so I think Charles, you have some background about the audience and what kind of things they are using. What kind of practice is going on in India right now? So please go ahead and share your experience and
okay.
tell us.
All right. All right. So just a second. Let me see. Let me see how to share my screen. Okay, got it. All right, so thank you so much, Vivek. It's for the introduction. It's really my pleasure to be here and spending about an hour to discuss with you guys about COVID-19 and the impact on our practice. So my name is Peng Zhang Charles from Beijing Friendship Hospital, which is affiliated to Capital Medical University in Beijing, China. I'm the chief of metabolic and bariatric surgery here. Our program is the largest program in China. So each year we are doing more than 450 cases of bariatric surgery. Today I'm going to share some of my personal thoughts and also some of our surgical practice guideline during the pandemic. So I don't have any disclosures. So I extract this map from the WHO World Health Organization. As of today, there are a total of 2.77 million persons infected by COVID-19, and there are more than 190,000 persons died from the COVID-19. Almost every country in the world had already had positive cases here. It's really, really a tough time for everybody. And this is separate. This epidemiology separated by the continental. You can see. So in Asia, the Western Pacific had the outbreak of COVID-19 earlier, then followed by Europe and the Americans, in the Mediterranean, and also now there's Africa. Looks like in the Western Pacific and the Southeast Asia, there's some more outbreak there. And these different countries, you can say in Europe, in the outbreak of the COVID-19 is on something like February 25th. And okay, let's say the Western Pacific, which is majority is China. The outbreak started on January 18th, and Europe is February 25th. It's about 6 weeks later than the China outbreak. If you see the Americas, like United States, is even another 2 weeks later than Europe, which is about 8 weeks later than China. For Eastern Mediterranean is the similar time as the Europe outbreak, and Africa is similar to the United States, and also Southeast Asia is some 8 weeks later than the Chinese outbreak. So this overview of the outbreak, you can see the different countries here. Yeah, it's a similar thing. Every Europe and in the Asia, West Pacific, into Europe, into America, and into the different world, in different part in the world. So if we so this mathematical model published by American CDC, Center for Disease Control and Prevention, the pattern of COVID-19 outbreak can be divided into 2 intervals: the pre-pandemic intervals and the pandemic intervals. And in the pre-pandemic intervals, there's a long incubation period, including the investigation, and people are going to suspect about that. Then you start to recognize probably there's a disease there, respiratory disease there. Then after that, can enter into the pandemic interval, starting from the initiation. Then after a few days initiation, then coming to the outbreak period, which is the first acceleration. Then the very fast increase of disease every day. Then you see a peak. Then you see a deceleration. Then at end of deceleration is the outbreak is almost ended. Then we're going to prepare for restart everything. So this regular pandemic pattern of all the respiratory disease. Let's see the outbreak of COVID-19 in China. So as of today, there are more than a total of more than 84,000 cases confirmed in China, and about 4,600 persons died from COVID-19. So you can see the wave, the peak is something like earlier, much earlier than the rest of the world. So this here, if we fit the curve, if we fit the pandemic curve to the outbreak of Chinese COVID-19, you can say, okay, so in late December, then the disease into the enter into pandemic interval, then starting initiation. Then in the mid-January, the disease enter into the outbreak period, which is first from mid-January to mid-February, it's acceleration period. And then after mid-February, then the outbreak start to decelerate until mid-March, which is end of the deceleration period. And then we now in the period of preparation for the restart, resume our normal life now. You can see the overall outbreak of COVID-19 lasts about 2 months. Yeah, then 1 month, which is acceleration, and the other month, which is deceleration. So this epidemiology of COVID-19 in China. Now, in our surgical practice, January 25th, which is our Chinese New Year, we have a whole week break starting from January 25th. Every year we have a whole week break due to Chinese New Year. So we during the holiday, all the elective surgery had already discontinued. And then we, after break, then still discontinued because of the pandemic. Now we stopped our elective surgery all the way to the end of the deceleration period, which is until mid-March. So on the March 16 in Beijing, the elective surgery resumed. But for every patient, as I mentioned, we needed to do the very strict screening for COVID-19 before patient can be admitted to the hospital for surgery. Now, after that, we are in this period. So till now, we still, for everybody, who want to see a doctor or go to hospital or do a surgery, and need to be screened carefully. Then we don't know when patient can go hospital or go to surgery freely. We don't know about that, but at least now the patient needs to be screened. First, I'm going to talk about our protocol during the outbreak period of the pandemic, which including acceleration and the deceleration period. During that period, you know, China is big country as India. India is also a big country. And China is a big country. Now, in the epicenter, which is Wuhan, is right here, which is Hubei province. Now there's the COVID-19 heavily attacked Wuhan city, and then around Wuhan there's some less cases, and far from Wuhan there are even less cases. So so we divide all the province into 5 levels. Let's say level 5, which is in the Hubei province, where the Wuhan city is. Level 5 province means that there are a total of more than 10,000 cases. Then the level 4 are the province with like between the 1,000 to 10,000 cumulative cases. And level 3 province, then between 500 and 1,000 cumulative cases, and the level 2, between 100 to 500 cumulative cases. And the level 1 province, then just like less than 100 cumulative cases. So we just classify all the province into 1 of 5 levels. And this is our prioritization of bariatric surgery by province. Okay, so for level 3, 4, and 5, mean each province, if the province has more than 500 cumulative cases, then they're going to avoid elective surgery. And for the level 2 province, we need to practice bariatric surgery with cautions. And for level 1 province, then there's a low risk. There are low risks for the elective surgery. So you can the doctor can do the elective surgeries. Yeah, but there's some point here. So number 1, even you can for low risks province, all patients must undergo screening protocol for the COVID-19. Make sure they are negative. And number 2, then let's say if a patient wants to do a surgery, they are from level 4 province, they can fly to level 1 province. Can they do that? No, the answer is no. Then they can, that level 1 province can only take care of the local patients, not the travel patient. So patient and travel across the province are discouraged. And then the number 3, the exception is that any hospital with a confirmed case should avoid bariatric surgery, elective bariatric surgery. This is also another guideline. So any hospital with a confirmed case should avoid bariatric surgery. So this is our national society guidelines during the outbreak of pandemic. And well, so during that period of time, we get prepared for the worst scenarios. And our practice was to minimize, postpone, or cancel elective procedures, endoscopies, or other invasive procedures. And in our hospital facility, we also minimize using essential resources like PPEs, inpatient beds, ICU beds, medical equipment, cleaning supplies, blood transfusion to get prepared for crisis. Now, we don't know when going to cause crisis, and we just get prepared for that. So spare enough beds, spare enough medical equipment for the potential crisis. So that's our practice. And also during that period of time, we wear appropriate PPEs in healthcare facility based on the exposures, including level 1, 2, or even 3 protections. And the other point is that we try to minimize working hours for our healthcare personnel, and let healthcare personnel stay healthy, and do not burn them out, and make them prepared for the crisis. Yeah, that's another important point. And we classify all the surgeries into 3 categories. Number 1 is emergency surgery. So what's the meaning of emergency surgery? So delay of the surgery might forever damage a patient's health, significantly reduce function, or cause death. And the second category is the semi-elective surgery. And this surgery, the aim of this surgery is to preserve health, life, or bodily function, but there is a larger window of time in which they can be performed. So there's a window to postpone the surgery. And elective surgery means that if you perform for the condition that don't necessarily imply health risks. So there are 3 categories. And also we classify patients into 3 cohorts. Cohort A patient means suspected or is a confirmed patient. Cohort B patient is patients under quarantine due to close contact with COVID RNA positive patients. So they have a close contact history with the positive patients, or the patients we don't know whether he's a suspect or not. Any person under quarantine is going to be cohort B. And the cohort C patients are those who confirmed without COVID-19 infection. So this is our classification on the surgery procedures and the patient cohorts. Here are a few examples of emergency surgery. So including, let's say, the patient in hemorrhagic shock, the patient in septic shock, necrotizing soft tissue infections, perforated viscous, and the airway emergencies, and also risks of ischemic bowel. So I am a bariatric surgeon. So some specific point for the bariatric surgery, including the perforated marginal ulcer, bleeding, acute anastomotic or staple line leak, and obstruction, particular due to internal hernia, and also gastric band perforation or prolapse. So these are some examples of emergency surgery. So this is our flow chart for all the emergency surgeries. We as I mentioned, the elective surgery was discontinued during the outbreak period. So we can take care of some emergency or urgent conditions. The first, for this condition, we need to classify patients. So which cohort patient should be? Let's say if a patient in cohort C that confirmed is a non-infected patient, if they got emergency condition, they can go to surgery directly. Okay, continue surgery. If the patient is a suspected or is a confirmed patient, if they are in the semi-elective or elective condition, so there's a window for postpone the surgery or cancel surgery. So going to cancel or postpone surgery if the patient confirmed as COVID-19 positive or is a suspected. And if patient in the cohort B means the patient that had the history, only have the history, travel history, or the history of close contact with the positive patients. And they will say if in the emergency life-saving condition, and the cohort A, they have in the emergency life-saving condition, so we have to do an emergency surgery. And the patients there's a window in cohort B, there's a window to postpone surgery. Okay, the semi-elective. So we're going to do a further testing for COVID-19. If shows a suspected or confirmed, then we can go to postpone surgery. If the confirmed there's no infection, so we can still do the surgery. So this is our flow chart for the prioritizing the surgeries. So let's say for the patient confirmed without the infection, so we in OR we use level 1 PPEs, and if the confirmed or cannot be confirmed, and I'm going to use a level 2 or 3 PPEs. So this table shows the level of PPEs. Level 1 PPEs, that's something like we are doing every day in our OR, including the scrub and the disposable surgical cap, disposable gloves, and also the disposable surgical gown, and disposable ear-lobe masks, surgical masks. So that's level 1. Level 2 protection, in addition to level 1 protection, so we need the disposable shoe cover, we need anti-fog, safety glasses or face shield, and instead of the disposable surgical gown, we need protective coverall suite. This is all we need, and also need N95 masks or higher masks. This is level 2, and for level 3 protection, everything is the same as level 2 protection except the masks. Instead of N95 masks, and this for level 3 protection is use a full face respirator or positive pressure head gel. So this is a level of PPEs. So why do we need a protection? So the goals of protection are to protect our patients, protect ourselves, protect our coworkers, protect our family members and relatives, and most importantly, protect our communities. And so the protection protocol need to be enforced in emergency room, in the fever clinic, on the way transfer patient to OR, when patient in OR, after operation, during recovery, all the way up to going home. Okay, let's discuss some details about our protocol. Okay, first on the road to OR, and the patient during that period of time, our regular clinic was closed down. So the patient needs to go to the emergency or fever clinic. And for emergency and the fever clinic, we have now it's kind of designated outpatient examine area. And also for the in the hospital, you need to designate patient transporting route. Okay, so from the ER or from your fever clinic, you should designate route to OR, which is very important. Okay, and the proper PPE are needed during transporting the patient. The patient needs to be fully covered. Patient need to wear surgical masks and the face shield, and also patient need to disposable surgical cap. And for the transport personnel, need level 2 or level 3 protection, and including disposable protective coverall suite, shoe cover, double gloves, and N95 masks, face shield or eye protection. And following the transporting, and we need to spray disinfectant following the route to disinfect the route. Yeah, we recommend use a chlorine containing disinfectant, which the concentration is like something like 500 milligram per liter. And if the elevator is used, and the elevator needs to be disinfected with chlorine containing disinfected right away. So this is our transporting protocol. Now, when the patient in OR, and this is a protocol. So the negative pressure OR strongly recommended. So it's great if you can use negative pressure OR. And that's then in the most of hospitals in China, we have 1 or 2 OR rooms which have the negative pressure system. Well, if the hospital does not have negative pressure OR, there's 2 options for that. Number 1, transfer patient to a hospital with negative pressure OR nearby, or just use extreme cautions when you do the surgery. When you do the surgery, if you don't have negative pressure OR, so you should not do any other procedures in the entire operating theater. You only do that patient after the patient is done. Just disinfect everywhere, then to resume your other surgeries. The other point that to have minimal number of personnel in the OR, no visitors or observers allowed in OR, and level 2 or level 3 protection required. And the point is that in intubation risk, which is for the anesthesiologists, then when do the intubation, and the surgeons and the personnel not needed for intubation should remain outside of the OR until anesthesia induction and the intubation are completed. And due to the pneumoperitoneum and other concerns, so that we should consider avoiding laparoscopy or endoscopy. And we also need to minimize using the electrocautery and ultrasonic device. When you have to use that, you use a low power setting and avoidance of long desiccation times. And then in the after surgery, we should minimize the use of drainage tubes, urinary catheter, nasogastric or oral gastric tube, and a gastric feeding tube. So that's our protocol there. And if you have to do a laparoscopic surgery, then the laparoscopic suction is recommended to remove surgical plums and decirculate the abdominal cavity, and try not to vent pneumoperitoneum into the room. We should use lower intra-abdominal pressure, something like 10 to 12 millimeter mercury if feasible. And we should avoid rapid decirculation of pneumoperitoneum. When we do a specimen extraction, and then it should be done with minimal CO2 escape. And also try to do very cautiously to minimize blood fluid droplet spray or spread. And also try to use the disposable chocas. Do not reuse that. And when you use that, check seals, make sure there's no leak of CO2. If there's leak of CO2, then it'll cause you harms, the potential risks to you. Then after operation, so the cohort A patient, which are patients have been confirmed without infection. Then, sorry. Cohort patient that patient has been confirmed COVID-19 positive. So after surgery, you need to transfer patient to designated room or hospital. Okay. And if the cohort B patient, you cannot decide whether it's positive or not. So we usually, when we start to surgery, and we already submit the RNA test, and we have to wait for RNA PCR test in OR until we got a result. If the result is negative, we can transfer back patient to the normal ward. If the result is positive, when you transfer patient to the designated room or hospital, if it cannot confirm, then treat this patient as cohort A patient, which are the positive patients. And the patient needs to change PPEs, and also surgeons and the surgical teams need to change PPE when exiting the OR. and all the surgical disposables need to be contained right away. And the minimal number of transport personnel, try to minimize the number of transport personnel. They should wear the appropriate PPEs. Then during the recovery period, and then a single isolated patient room is needed. So strictly single room. Now make sure there's no roommate in the room. And when for the doctor in that room, there's doctors and the nurses should be also have a team to take care of the positive patient, the designated team to take care of them. And they use level 2 PPEs when when carrying the COVID-19 positive patients. And the rapid recovery protocol, ERAS protocol, is strongly preferred. And the important part is that do not discharge patients until COVID RNA PCR test becomes undetectable or negative for at least 2 times. And you have to test 2 times before you discharge patient. And the 2 times test should be more than 24-hour intervals. And both tests should be negative, then you can discharge the patient to home. Otherwise, you just keep patient in your hospital. And that is our surgical protocol during the outbreak period of COVID-19. And also when for our patient care, now some patients need to follow up, some patients need to, for some consultations, so we need to continue to take care of our patients using online seminars, the use of teleconsultations, and also for some patients, they want weight loss, we usually recommend them to use non-surgical weight loss approaches. So that's our protocol for take care of the post-op or pre-op patients. All patient has undergone surgery long time ago. And these recommendations for metabolic and bariatric surgery during the COVID-19 pandemic, and from IFSO, and my colleague CC Wang, and also the IFSO president Lilian Cao, and also the president-elect of IFSO Scott Shikara, and also Wang Yang, who is the president-elect of IFSO Yang. They published recommendations as editor on the obese surgery just a couple of weeks ago, which has a very detailed protocol on how you take care of your patients. And I recommend you can read that paper on the obesity surgery, and including the following chapters. 1 is general recommendations, then the screening and the diagnosis protocol, and emergency surgery for treating post-operative complications, and the protocols for suspected or confirmed COVID-19 cases. And there's a chapter about patients recovered from COVID-19, follow-up and integrated health aligned support. And also there are some guidelines for the academic activities and conferences, and some suggest to the general public with obesity and metabolic disorder. And also there are some suggestions to for the preparation for returning to normal clinical practice. It's worth to read that. And it's quite similar as our practice guideline. Well, so now, as I mentioned, on the March 16th, starting from March 16th, we resume our elective surgeries, but need COVID-19 screening before admission. So now we are prepared for restart and resume to our normal life now. So I'm going to talk about the protocol during this period of time now. So as I mentioned, elective and the semi-elective surgery have been resumed. So, but still, for every patient who needs to be admitted, we should do a COVID-19 screening. And if the patient is negative, well, so can continue surgery. If the patient is suspected or positive, then still we have to postpone surgery, postpone the semi-elective or elective surgery, and let patient just treat COVID-19, make COVID-19 negative first, then they can come back for surgery. And the patient is in the cohort B, and with all the screening, still cannot confirm which cohort. Then we suggest patient wait for another 2 weeks, then redo the screening. So if the is negative, you can do the surgery. If after 2 weeks is suspected or positive, then we have to postpone surgery. So that's our current protocol. And for the COVID-19 screening protocol, including 4 parts. One is we ask patient travel history and the contact history, whether patient contact to somebody who are suspected or are positive, and if patient have ever traveled to epicenter like Hubei province in Wuhan city. One. Number 2, we take the symptoms from patient, including fever, ask them if have fever, cough, shortness of breath. And for number 3, we do the complete blood count on everybody. And also we test CRP, C-reaction protein on everybody. We find that CRP is a sensitive parameter. And then on every patient, we do the chest CT as a screening protocol. We find that chest CT is more specific than the RNA test. And if all these are negative, then the patient can be admitted. If any one of these 4 criteria are positive or suspected, and then we go to the COVID RNA PCR test. That's a screening protocol. And well, so as I mentioned, for the continue, now we for the elective surgery, if the patient without any infection, so we still use a level 1 PP as our normal practice in OR. Well, as I mentioned, we're still in this period. We are prepared to returning our normal life, but still everybody need to be every patient needs to be screened. And also we now, as I mentioned, I work in Beijing. We can only take care of patients from Beijing locally. We cannot take care of patients from other province. So that's in this period. So we don't know when we can return to normal life. We don't know when that happened yet, but there must be a long wait, I guess. Well, yeah, I got another, I extract another graph from World Health Organization website. So this is India, the number of the COVID-19 in India. So far there are 24.5 thousand persons confirmed cumulatively, and something like 775 persons died from the pandemic. Now, let's fit this curve again, this mathematical model again. Looks like India now still in the acceleration period, still in here. This acceleration period is starting from late March or early April. Looks like still need time to reach the plateau, reach the peak, then can decelerating. So this might be the current situation in India, but I'm not quite sure about that. So this data just from WHO. Well, so our practice that when this in acceleration and the deceleration period phases, we call that outbreak. So our practice that during this outbreak period, we have to freeze elective surgery, emergency surgery is okay, semi-elective, you should consider about that. And looks like the India is still in this period of time, and looks like it's not ready to return to restart elective surgery yet. And well, so after that, I also recommend just resume your elective surgery, but you also need strict COVID screening. Probably, let's say, probably 1 month later, who knows? As I mentioned, China is a big country, and India is also a big country, have many states and union territories. Also, each states are quite different. It's quite different. Let's say, so for these states, you say there's more cases, but most of states you don't see just like single digit or less than 100 cases cumulatively. So that's quite similar to China condition. Also, then probably this pyramid might be helpful for you guys. Just my personal thoughts. Okay, so you do the level 1, level 2, 3, 4, 5. You classify that. See in your state, well, is how severe the impact of the COVID-19 is. If in your province you're just a single digit or less than 100 cumulative cases, I don't think you have a reason to freeze your elective surgery. But as I mentioned, you have to do a screening. You do screening, and probably some patients still positive. They are not screened yet. And for the 100 to 500 community cases, you should practice with very cautiously. And if your state, there are a total more than 500 community cases, well, so probably just get prepared. Just don't do elective surgery right away. Just get prepared, and who knows? There's a even severe outbreak someday. Who knows about that? So this is my personal thoughts. Okay, and also, and I think this 3 points is really helpful to our practice. In my practice, so in our society, Chinese Society for Metabolic Bariatric Surgeries. So we have this point. Number 1, so in the low risks area, and also in the level 2 states, all patients who want to undergo elective surgery, they must undergo screening protocol before they are admitted. Number 2, don't do patients from other states. Yeah, they might come from epicenter, from somewhere you don't know. They can infect your patients and your cause infection in your hospital. So just do the local patients. And also, if any hospital with a confirmed case, and well, so there might be a risks for the rest of patients and the entire environment. So just avoid elective surgeries. So there's some take-home messages. Number 1, try to keep optimistic. Yeah, so tomorrow will come for sure. We don't know when we'll win the battle against the COVID-19, but we are sure we will win. And suggestion to our folks, our colleagues, and just continue to stay healthy and don't burn you out. Just save some energy. The reason, there are 2 reasons. 1, if you don't burn burn out yourself, and well, you have a stronger immunity function. And number 2, if there is a crisis coming, you have more energy to save more patients. Okay, and the other point that also our practice has been freeze for like more than a month or even 2 months. So we have a lot of patients on our pipeline. So we are for sure be even busier tomorrow than anytime. So just get prepared. All right, thank you so much. That's my talk, and very happy to take any questions. Thank you.
Thanks, Charles, for that wonderful presentation. And I think everyone is appreciating the way you have covered the topic and individualized it to India as well. So you give very nice protocols and very clear-cut answers to a lot of questions which all of us are pondering on a daily basis. The pre-operative protocols, the intraoperative protocols, the post-operative protocols, when to start, when to stop elective surgeries, how to differentiate between elective, semi-elective, and emergency procedures, what to do if a hospital has a COVID patient, what to do in the, what are the levels of PPE. I think all of those are very, very important aspects. And we are recording this meeting and we would share the link for everyone to see it again. So I will just take up questions, and I have some questions to ask you. So see, once we are doing these cases in a theater, so we are used to, like in our setting, we do around 5 to 6 cases. We used to do around 5 to 6 cases per theater per day. So if we are running 4 theaters, we are doing 15 to 20 cases in a day. Now with this all, if you are using PPE in all the cases and taking all the precautions, we are unable to understand how can we reach our previous volume. As in, we will be always we'll be donning it, doffing it, and a lot of precautions to be taken. So what do you say? How, do you have a separate donning and doffing area of PPE in the OT? And do you change PPE in between the cases? So like, you know, you do one case, you take off the entire PPE, then you wear another one for the next case. How do you do it?
Yeah, so during the outbreak period, we change PPE. Even when we exit OR, the OR, which is negative pressure OR, we change our PPEs. We use a lot of PPEs during that period of time in OR. Yeah, for every patient, we change all the PPEs just to dispose of the PPE, and then do the sterilization of the OR on the disinfecting the transfer routes, and do everything. We are really cautious because, you know, each hospital don't have so many emergency cases each day, so you have enough time to take care of all the precautions.
And now once the outbreak is over, then you don't use PPE in all the cases?
So now we don't use PPE because we screen every patient who is already negative, and the number of the new cases in China is like each day single digits now, just a few. So if there is a positive case, we don't take. So now we don't take positive patients. We just transfer them to the designated hospital. So in Beijing, there are 2 hospitals who specifically take care of the COVID-19 patients right now. So if for those patients now, they want to do emergency surgery, we transfer patient there. So we don't take care of any positive patient right now.
So in India, a lot of hospitals have started with RT-PCR testing for COVID before surgery. But the problem is false negative reports, which is a significant push. Reports will be false negative, and you'll end up operating on a positive patient who had a false negative report. So that's why everyone is kind of trying to use PPE for all their cases, irrespective of the pre-operative testing report. How do you, what do you say on that?
I think that's right. That's correct. So when during the outbreak, which is acceleration and the deceleration period of time, we also you know, for every emergency surgery, now we are very cautious about that. Very cautious about that. So we.
Yeah, Charles, I think we can't hear you. Charles, we lost your audio. Yeah.
Hello? Hello?
Yeah, now it's okay.
Okay. Okay. Okay. Good. So what? Yeah. So we are very cautious about that. So every patient has been screened, and you know that during outbreak period of time, there are patients, you know, outbreak period of time, there are a lot of patients right now, on the market, on everywhere. So you be treat every patient as suspected or whatever, unless you confirm they are negative, right? So you should be cautious on everybody. PCR is there's a high rates of the false positive or false negative. So we use our screening protocol. One is the history, travel history. Number two is is symptoms. Number three, there are some CBC tests and the CRP. Number four, the chest CT, right? So use a combination of all the tests you can. And sometimes chest CT is more specific than the PCR test, RT-PCR test. So that's our practice.
Because
yeah.
There was this question also from 2 or 3 people about chest CT in asymptomatic patients. Is it sensitive enough for checking for COVID?
It's very specific. It's not that sensitive. There are some patients without any symptoms, right? So, but it's very specific. If you see some phenomena on CT test, then there must be a suspected cases. So you should try to avoid postpone surgery, cancel surgery, or if the live surgery, you could just continue your surgery. So use a combination of the test.
Yeah, there is one concept here regarding, that almost 70 to 80% of population needs to get infected before the herd immunity. And that is when the number of cases would go down. While you are saying China had just 82, 83,000 infection, and now China is kind of, without any new infections or in single digits. So is it a wrong thinking if we think that, it is going to stay for a year or two, because that is a major concern of everyone. It's not going to die out in a month or two. People are thinking that it's going to stay till 70% of people are infected.
Yeah, so I'm not expert in the epidemiology. I don't quite sure about that. How long the pandemic going to last, and when the vaccine going to be on the market. I don't know, quite sure about that. But but now we still practice very cautiously. As I mentioned, for every patient, patient want to go to clinics, outpatient clinics, or do a surgery. So we have to do a very strict screening on them.
All right.
Yeah.
So a lot of questions there. I think people want to, there are a lot of surgeons who want to ask, what precautions do you take when operating on COVID in emergency? I think you answered that. Minimal excess surgery, you answered. So Dr. Amit Gupta is asking, after performing surgery, should one stay in the hospital or go home to family? So I think that's
that's a good question. After surgery, well, it's a negative. You for sure, for following all your screening protocol, you confirm patient is a negative patient. Then you can do it as your regular protocol. Just after recovery, you can go home. If the suspected or is positive, so you have to wait until the COVID-19 become negative before they go home. So you don't want to spread the virus on you in the patient community. So make sure it's become the negative. And also we need 2 times tests, including 2 PCR tests, consecutive tests with more than 24 hours interval.
So Charles, how many healthcare workers did you see around you getting infected from surgeries? Like, somebody operated on someone, like there were a lot of cases like that?
No, we start to recognize COVID-19 in probably something like January 20th. Okay, after January 20th, for the surgeons there, I'm not quite sure. There are just few surgeons got infected by the operating on the positive patients, and before that there might be some. And a total based on the I forgot that number. Based on the statistics, probably a few hundred patients, a few hundred doctors got infected, and not quite sure about that. And I don't remember that number. Probably a few hundred doctors got infected, but that infection was happened before January 20th, when we recognized the disease, recognized the COVID-19.
Yeah. Dr. Ashish Gautam is asking about RT-PCR for COVID-19 to screen the patient before surgery. I think you answered that it is a part if suspected patients. Dr. Nandkishore Dukipati wants to ask if patient comes back after few days post-op with COVID symptoms, how do you handle and what are the medical legal implications? So if you operate on a patient, he was COVID negative pre-operatively, you did a surgery and now he comes back with a COVID positive report. Are there a medical legal implication for the hospital or any kind of problems?
Well, that's got problem. We have to now we have to quarantine patients, send patients to the designated room or the hospital, and also we need to quarantine our coworkers who have ever take care of the patients. That patient, so we quarantine our any personnel, any health personnel who care the patient. We need to quarantine them for 2 weeks.
Okay.
Yeah, that's our practice.
So Dr. Selva Shekhar is asking, what common complications do you see in COVID positive patients? Any specific complications which you saw in COVID positive patients?
I'm not quite sure. I'm not quite sure about that, but there's some evidence from hospitals in Wuhan, which is the epicenter of COVID-19, and the mortality rate was much higher in COVID-19 positive patients than the negative patients for emergency surgery.
We also read a paper which said that mortality rate of asymptomatic COVID patients was quite high.
Yeah, something like 20%.
Yeah,
looks like. Yeah.
Okay. Do you do antibody tests? Dr. Ramesh is asking, are you doing any antibody testing for COVID patients?
No, not right now. That's COVID-19 antibody test going to be for the epidemiology, probably for that purpose. Want to know how many person got infected by the COVID-19. So we don't routinely practice that in our hospital.
Yeah, I think, and there's a very relevant question from Dr. Sangtam regarding traveling of patients. So traveling of patients in between states or provinces is very common in India, as it must be in China, to go to larger cities.
Yeah.
So what is the protocol now there? Are people traveling in between provinces? Is it allowed? Is the air travel open? How does it work?
The lockdown policy like that for all the flights and train to Wuhan are discontinued or discontinued. So there's the person in Wuhan city, they cannot get out of city because of city lockdown. And for other province, and if a patient wants to do the surgery, they just travel to get the surgery done. So it's also not allowed. And but now after the outbreak, we resume the normal the elective surgery. If a patient wants to do surgery from other province in Beijing, so the patient has to be quarantined 2 weeks in Beijing at first, then can come to us, and we're going to do the screening protocol and try to admission protocol. So 2 weeks quarantine.
So the patient, if he changes the city, he has to be quarantined for 2 weeks?
Province, like something like a state in India.
So if he
across
changes
the state.
If anyone changes the province, he will be quarantined for 2 weeks before he can enter that hospital.
Yes, that's right.
And is the air travel open? What did you say? I missed that.
It's very limited open.
Very limited.
Very limited. Yeah.
What about road travel and all? It is all restricted across those provinces.
It's it was not, the road travel was okay, but during that period of time, nobody want to travel. They want to stay home for safety concern.
Right.
Yeah.
So Dr. Vikas Singhal is asking, is one negative test before surgery enough, done 24 hours before the procedure? So I think you answered that you don't do a negative test. You don't do a PCR test anyways until you suspect it.
Yeah,
Any alternative of negative pressure operating rooms? So I think that is a big question in everybody's mind. Dr. Ankit Shah is asking the same, because in India, practically no one has a negative pressure OR. So the only thing is you can open all the windows and just make it into a ventilated place.
Yeah, that might be a problem.
And now today, so now after the pandemic is over in your place, you are operating in your regular positive pressure ORs, right?
Yes.
So I think that is what Charles mentioned in his presentation, that during the acceleration phase and during the pandemic, early deceleration phase, do not operate in a positive pressure OR, but as you reach the end of the pandemic, you can start using your positive pressure operating rooms. And I think that's a good question, which a lot of people do not have answer to. You actually have to change the air handling unit of your OR, which is a huge expense and a huge infrastructural change as well. What about surgeons? Okay, what precautions in asymptomatic? Maybe. How do you interpret the CBC and the CRP? Two people, Dr. Garg and one more surgeon asked it. How do you? What are the cutoff values?
Well, just there's not a clear cutoff point for that. So just give a signal that we should be cautious about that patient. If the lymphocyte is much higher, it looks higher than normal, and we may just do additional tests. Let's see, we need to confirm if, let's say, if the lymphocyte is higher than normal or CRP is abnormal, so that tell us the patient needs to do the PCR test.
Okay, so any abnormal values would be a red flag.
Yeah, so, a red flag. Then the patient needs to be confirmed with PCR.
All right. Dr. Vikram Aryan is asking the protocol to evacuate pneumoperitoneum. I think you mentioned to use a sucker there without exposing the pneumoperitoneum into the operating room air. And so Dr. Pramod Shinde is asking about quarantine of involved people with PPE. So if a surgeon operates on a positive patient, he turns out to be positive later, and so, and they have used PPE, does that area or the entire hospital needs to be closed? I think there are a lot of guidelines there now coming up with Indian authorities also, that if you have used proper PPE, you don't need to be quarantined. You just need to do a thermal check twice daily for next 2 weeks, in case the thermal check turns out to be positive for any healthcare worker who was involved in a care of a positive patient, whether operating or non-operating. He needs to be then quarantined and tested. But otherwise, if you have taken adequate precautions, you don't need anything except for thermal checks. What is the classical finding in? So Dr. Ashish Vashisht is asking, are you doing all surgical cases laparoscopic now?
Yes.
Okay.
Yes, we do. Yeah, we do everything as our normal life, except every patient needs to be screened before admission.
All right, wonderful. And do you use HCQS? Dr. Khattar is asking, do you use HCQS for prophylaxis of healthcare workers? Hydroxychloroquine?
What is that?
Hydroxychloroquine. Did you use that drug for prophylaxis of healthcare workers? So India, the Indian Council of Medical Research recommended hydroxychloroquine prophylaxis once a week for healthcare workers.
Well, so there are no evidence on that. There's no, we use that on the patients in China. Use that drug for other patients, but there looks like finally we find out there's no evidence that drug going to be effective enough, and so now we actually we don't use that, especially don't use that for prophylaxis for the doctors.
Okay, so I think that has been the experience in most countries. There's not a lot of evidence to suggest, but it has been recommended, and a lot of healthcare workers have been using it in India. Dr.
Oh,
Shashank Shah, the senior bariatric surgeon from Pune, is asking how do we dispose the PPE after every case? Is there a disposal team with PPE, and how to sterilize them before disposal? Do you have any idea about disposal of PPEs,
yeah,
Charles?
yes, we right after surgery, we dispose all the PPEs into a double bag,
Okay.
and in double bag, and just somebody gonna take that to the designate sterilizer, and
Do you take them off in the OT itself? Do you take off the PPE in the OT itself, operating room itself?
you mean
How do you remove the PPE? Like do you take them off in the operating room, the PPE, or do you have a separate area for removing the PPE?
it depends. It depends. You know, in the OR we have a specific area. Now, when we enter OR, we have the PPEs, the negative. You know, if you have negative pressure, OR, we have all the flow chart, the different rooms. There's a room there to change your PPE. Okay. Yeah, so we have different entrance. We also have a different entrance for negative pressure OR.
All right.
All the positive patient going to be operate in the negative pressure OR.
I think everyone needs to understand that what Charles presented about operating today is after the pandemic has played out and now there are no new infections in his area. So that is when he is doing all these surgeries. But we are at a very initial stage of acceleration right now, and we cannot apply those things to India. So during the acceleration phase, they also stopped their surgeries for almost 2 months, and they did not do any elective or semi-elective surgeries because
That's
it's
right.
very difficult to take all these precautions. And we cannot replicate what Charles has said. It can be replicated after we have reached that level when it is the late deceleration phase of the pandemic in our country or in our region. So that is something which we need to remember. I think a lot of people want to talk. There are a lot of more questions also. I can take them up, but it has been 1 hour and 15 minutes. We are 15 minutes overshooting the time, and Charles had a busy day. This is what he told me. Charles, any last comments you would like to make?
Yeah, my comments that try to stay safe. That's very important for yourself, for your family, and for your patients. We should to stay safe, stay healthy, and keep optimistic. Yeah, that's my suggestion. Sooner or later, you know, we'll win the battle against the COVID-19 virus. But there might be a second wave. From now, get prepared for you are very cautious about COVID-19. Whenever you do your surgery, you practice your surgery, and use cautious.
All right. Thanks, Charles, for that. We had more than 100 viewers on LabGuru, and there are a lot of questions which have been forwarded to me on LabGuru. Most of them, I think, have been taken up in the discussion we had. Dr. Manas Sahu, Dr. Durga Subramaniam, Dr. Keyur Gutte, Dr. Mitab Goel, Dr. Hemendra Singh, Dr. Anand Nagar, and lot many others have asked questions which have been discussed. I would like to thank all the viewers who came in. I think this is very interesting, and this is the question in everybody's mind when we would return back to our practices and our operating rooms. But as Charles told us, it is the early part of epidemic. We should not be non-cautious. It is better to stay safe than sorry. And once we have a deceleration phase, which hopefully we will get because our government is acting in a good way by extending the lockdowns, and we hope that we will be able to get over this pandemic. We'll have more discussions with international panelists from US, Italy, Spain in times to come about situations in Western countries also. So I would request everyone to join Clinical Robotic Surgery Association. We'll have a lot of international panelists for surgical procedures as well as for these COVID scenario talks. So for joining Clinical Robotic Surgery Association, you have to go to our website, clinicalrobotics.com, and you can click on the Indian chapter. The Indian chapter membership is highly discounted. It's just $100 as opposed to $300 annual membership of the CRSA International. I would take leave this evening, and I would like to thank Charles again for such a wonderful insight. And we would like you to be a part of our panel later this week also once we do it again.
Thank you, Vivek.
And thank you all the attendees for listening to us and being a part of this meeting. Thank you. Stay safe, everyone. Bye-bye.
Bye-bye. Thank you.